the opportunity to give you a summary of what we presented at ESMO. What we discussed was actually a study that was specifically for patients with breast cancer. And just to give you a little bit of background, patients with breast cancer, the indications currently for immune checkpoint inhibition is somewhat limited to those who have high-risk early-stage disease or metastatic triple-negative disease with high CPS or high tumor mutational burden. So there's a lot of improvement for expanded indications. So combination therapies have been studied as a way to prime the tumor microenvironment to improve response rates and clinical benefit from these agents. And we and others had investigated whether the use of epigenetic modulation using the histone deacetylase inhibitor entinostat could actually prime the tumor microenvironment and improve response to immune checkpoint inhibition. And our preclinical data supported this growing body of work that found that there was improved survival in preclinical models that were treated with entinostat and anti-PD-1 and anti-CTLA-4. So this is what we use to base our design of a phase 1 trial to test the safety and novel combination in patients. And the first part of the clinical trial was in advanced solid tumors. And what we presented at ESMO is actually the results from our planned expansion cohort in patients with HER2-negative breast cancer. So in this dose expansion cohort, patients with advanced HER2-negative breast cancer who either had prior exposure, they did not have prior exposure to immune checkpoint inhibition. They were treated with a recommended phase 2 dose, which included 5 milligrams of weekly entinostat for a 2-week run-in period, and then 3 mg per kg of nivolumab every 2 weeks, and 1 milligram per kilogram of ipilimumab every 6 weeks. And we had done blood and tissue biopsies collected prior to the entinostat run-in, after the 2-week run-in, and then at 8 weeks after the addition of checkpoint inhibition. So we had 18 patients from the dose expansion cohort, and then 6 patients that we included with breast cancer from the dose escalation cohort to bring us to a total of 24 patients who received the combination of entinostat plus nivolumab and ipilimumab. The patients enrolled were about 55 years old. Half of them had hormone receptor positive breast cancer and half had triple negative breast cancer. And just to note, this is a patient population that was heavily pretreated with a median of 6.5 prior therapies. We observed possible immune-related events that were similar to those reported in the dose escalation. Notably, there were only 2 patients who had higher grade adverse events, and which included a grade 4 increase in lipase and a grade 5 respiratory failure, but these were presumed to actually be not immune-related. So the exciting part of our presentation noted an objective response rate of 30%, with a response observed in both hormone receptor positive and triple negative subtypes. And the majority of these responses occurred in patients with triple negative breast cancer. And 1 patient actually had a complete response at the 6-month time point. The duration of response ranged from less than 2 months to the longest response ongoing at greater than 24 months after the initiation of our treatment. The median progression-free survival was short at 2.5 months, and the overall survival was 7.7 months in all patients, 24.4 months in patients with triple negative breast cancer, and 5.9 months in patients with hormone receptor positive disease. Of note, those driving improved overall survival are the patients who experienced response. We also discussed some of our correlative studies that investigated immunohistochemical staining of T cells, and that demonstrated the ratio of CD8 T effector cells over FOXP3 T regulatory cells increased after therapy from baseline to time point 1 and to time point 2. And this is primarily as a result of increased CD8 infiltration. And this was most notable from patients with triple negative breast cancer. We also mentioned there's no obvious trend in abundance of tumor infiltrating lymphocytes at baseline across the breast cancer subtypes or with treatment. And so this is not likely going to be a reliable biomarker of response in this setting. So just to summarize, the combination of entinostat, nivolumab, and ipilimumab administered at the recommended phase 2 dose was associated with expected immune-related adverse events. An objective response rate of 30% suggests this combination really should be evaluated further in a phase 2 setting in advanced HER2-negative breast cancer. And correlative results suggest an increase in CD8 to FOXP3 ratio after treatment and should be investigated in future studies as both a mechanism and potential predictor of response. Future investigations for potential biomarkers and mechanisms of response are ongoing and include bulk RNA sequencing as well as imaging mass cytometry to investigate other important immune cell infiltrates such as myeloid-derived suppressor cells. And future clinical trials are planned to investigate this promising therapeutic combination in a large cohort of patients with breast cancer. It was great to have the opportunity to discuss this. And of course, we always thank the patients and their families who contributed to making this study possible. And Dr. Rasheen Connolly and Dr. Vered Stearns, as well as my mentor from Johns Hopkins, Dr. Elizabeth Jaffe, supported all of this work. And as we continue to really dive deep into the correlatives that we hope to teach us more about, the responders in this study.